Boom. Okay, hi everybody. Welcome to our community health class again. So today we're really lucky. We've got somebody from Albany Medical Center with us. Rachel Robinson is with us. She's a licensed mental health social worker that's with us, and she's at the Alzheimer's Center of Excellence at Albany Med. So she's so graciously volunteered to come visit our class tonight or this afternoon. I don't know what time of day it is you guys are watching this. So welcome again, Rachel. Thank you so much for coming.
Thank you, Anne. Yep, my name is Rachel. I'm a licensed master social worker, and I am the program coordinator here at the Center of Excellence for Alzheimer's Disease, or the Alzheimer's Center at Albany Med. I always like to explain a little bit about who we are and what we do to start us off. So that's what I'm going to do. Oh, that's our title. I'm going to start here at the Centers of Excellence for Alzheimer's Disease because not a lot of people know what they are and why they were created. They were created in 2016 by the Caregiver Support Initiative, which is the first of its kind in the nation. New York State is the only state in the country to do this. There are 10 Centers of Excellence for Alzheimer's Disease. Every county of New York State is covered by a center. So our center up here at Albany Med covers the capital region, some of the surrounding counties for a 10-county catchment area. I like to describe what we do kind of in two arms. And yes, I always use my hands when I do that. I don't know why. But you know, the one arm of what we do is why I'm here talking to you today, right? One arm that we do is outreach and education to any healthcare professional who's going to work in the healthcare field with adults who might encounter Alzheimer's disease or dementia. So that means presentations about Alzheimer's disease and dementia, and it encompasses nurses and social workers and primary care doctors and neurologists and anybody who might run into them, literally anybody. It also encompasses working with caregivers and doing caregiver education and that sort of thing, right? On the other hand, what we do is we're a specialty outpatient neurology clinic, which means we see patients all day. I have a team. I have 3 providers. These are my 3 providers, Dr. Zimmerman, Dr. Hart, and Dr. Selmans. And then this is our team. We have an RN, we have 2.5 social workers, a research nurse. Nancy is our program director. She's incredible. But when we see patients all day and as a team. So it's a interdisciplinary team-based approach for our patients. And I'll talk more about what a visit looks like further on. But our agenda today, we're going to review Alzheimer's disease and dementia. We're going to look a little bit of brain imaging. And we're going to overview that new visit here at the Alzheimer's clinic, what it looks like when we're looking for Alzheimer's disease and dementia. And then what we're really going to focus in on today, because this is community health, is we're going to really focus in on a comprehensive review of community resources that exist here in the capital region in my 10 counties. Typically, if I were to do this live, I would ask people, does anybody know the difference between Alzheimer's disease and dementia? Because I think it's a question we get often. And I've gotten all different types of answers that run the gamut from, it's kind of like the rectangle and the square, you know, Alzheimer's is dementia, but dementia isn't Alzheimer's, right? I've gotten that one.
It is so hard, Rachel, to figure out those differences and really be able to pinpoint which is which. I don't know how you do it.
Well, you know what? It takes a lot of practice, and it takes understanding the diseases, right? So dementia is the disease. Dementia is the disease process. It's the symptoms that we see. It's a progressive neurodegenerative disease, which means it's going to get worse over time. And my patients don't recover, right? When you have dementia, you see a progressive decline in the person's cognitive functioning. They're going to have difficulty thinking. They're going to have memory loss. And eventually that's going to eat away at that person's brain. And there's really no nice way to say it. The brain atrophies and dies off until the person dies, unfortunately.
Yeah, there's no nice way to say that.
There's no nice way to say that.
Yeah, it's awful.
It's terrible. And it's a really hard disease for my caregivers and my patients. It's emotionally, it drags my caregivers through the mud. It really does. So I just want you to imagine for a moment that this could be a patient you're caring for, or a loved one you know. someone you've met, right? Maybe this older woman, they might look like someone you know, they might not. But for a minute, think about what it's like to travel with a person that sees themselves in their reflection, right? They might be acting like everything's fine, but what they could be experiencing internally is very different from what they're showing on the outside. My Alzheimer's and dementia patients, maybe they're reminiscing about what they could have done. Maybe she looks in the reflection and she sees who she used to be. She doesn't see the older woman that she knew. Or maybe she looks in the mirror, or she looks in the reflection, she sees the older woman that she is, but doesn't realize that it's her, because that doesn't look like her reflection. She doesn't recognize herself in that reflection, right? Now imagine that the woman sitting next to her is her daughter, but maybe my older dementia patient doesn't recognize her. Or maybe she thinks it's a nurse that's caring for her, or an aide, or a companion, someone who's there with her, right? That's something that dementia can really start to look like. And really, my patients can look like they're traveling through time. They might act in ways that people think is strange. Sometimes people with dementia lose their ability to understand when they are and where they are and who's around them, even if they've known them for forever, even if they've been in this space for years, right? They tend to move backwards in time. And I say this a lot to my caregivers. With the progression of the disease, which we'll talk about, there's really a regression of the person's ability to do the things they used to do, but also a regression in their behavior and how they speak and how they act. They move backwards. So when we talk about dementia, we talk about dementia as an umbrella term. There are lots of different types of dementia. There's almost like 200 types of dementia, and that might be like on the smaller side. I don't know them all. Yeah, it's a lot. I don't know them all, but these are the big ones that we see in our clinic most often, right? And when we talk about dementia, we're really challenging people to start talking about dementia and thinking about dementia the way we think about cancer, right? Because what are the two types of questions that we ask most often when someone says to us, I have cancer?
Oh, well, what kind is it?
Type.
Right? And what's the expectation? That's what I think. What's the expectation? Like what are you going to do for that?
Yeah, or
your outcomes.
Your outcomes, or how long, maybe.
Yeah.
And when we think how long, we think, well, what stage are we in?
Right. What stage?
Right.
Absolutely. You're right. That is exactly what I think of before I go there. Yeah.
Yeah.
Yes, I do say what stage.
Yeah. We think of an outcome, but we think of an outcome because we know that there are different stages.
Yes, absolutely. Right? That makes sense.
Yep. And so these are the ways that we want to challenge people to think about dementia, right? We're going to focus in on Alzheimer's disease today because Alzheimer's disease really is a great majority of our dementia patients. More often than not, in any stage you see a patient with dementia, chances are they're going to be Alzheimer's disease. Now, you might see a little bit of diagnosis like mixed dementia or dementia, right? Really what that means is that they might be somewhere in between Alzheimer's disease and vascular dementia. Maybe they're both. Vascular dementia is a dementia that sets in when the person has had a stroke and blood flow can't get to the brain, or lots of little strokes. And there's changes in the brain from all those little strokes, those TIAs, right? So that's what we see, sometimes mixed dementia, but really we're going to focus in on Alzheimer's disease.
Okay.
All right, this is just another visual for you. Again, 60 to 80% for Alzheimer's disease. It's a vast majority. And again, vascular dementia we see Parkinson's dementia. I know a lot of people focus in on Parkinson's because they think the hand tremors. And Parkinson's disease has a dementia component, but it doesn't always. So that's an interesting caveat that I wish I could delve into further. I always like to show this graphic from the Alzheimer's Association. This is Know the 10 Warning Signs. These 10 warning signs have not changed. They are still the same 10 warning signs. And these are the things that people notice most often when they start to notice memory changes, either in their loved ones or their patients, right? These are the things we notice. Memory loss that disrupts daily life, challenges in planning or solving problems, difficulty completing familiar tasks, right? maybe trouble with driving, visual spatial relationships, seeing where you are in relation to the curb when you drive, right? Misplacing things and not being able to retrace your steps back to find where you put the thing that shouldn't have gone there, right?
Yep.
Maybe withdrawing or a change in mood and personality. Maybe they're angry more often, right? These are things.
Mood change.
Mood change, yeah. These are the things that we see tip our caregivers off early most often. Some epidemiology for you, right? Alzheimer's disease is the most common cause of dementia, and yes, it does affect more women than men, which means that 2/3 of our patients are women. Why do we think that it affects more women than men? Because women live longer.
Oh, of course.
Women live longer. That's just it. And
Okay.
it's right. Life
That makes
expectancy
sense.
for women. And the number one risk factor for Alzheimer's disease is age. There are other secondary risk factors like lifestyle and all of these other things, right? But women live longer and age is that primary risk factor. We also see higher numbers of Alzheimer's disease in our minorities, our African Americans, our Hispanics of any type, but we don't typically see them in our clinics, in our neurology clinics. Any guesses why we don't typically see them in our neurology clinics?
I'm going to say because they tend not to get the same level of healthcare.
Yep.
Fortunately, right?
Yeah.
Yeah.
Well, they tend not to get the same level of healthcare. There's a lot of social factors.
Oh,
right?
God, yes.
The first is, social determinants of health. They don't get the same level of care.
Absolutely.
But there's other things like, different cultures handle illnesses.
There's a lot of cultural reasons why it happens. Absolutely.
Yeah, all of that. And then
Right.
and then you have to think about, the historic and systemic racism that affects those communities of people who just don't trust their healthcare system.
Absolutely.
Their healthcare providers, right?
Mm-hmm.
And so they go to some other sources of support to deal with this. And so we don't see them come into our clinics, but we do see higher percentages with Alzheimer's disease, right?
I hope we see some change in that going forward.
So we are seeing some changes. There is a proposal, a new goal was accepted to a national Alzheimer's disease research proposal initiative in New York State. And it's a big partnership among all the leading players, but the newest goal that was finally accepted was research on those social determinants of health.
Wonderful.
For specific cause. So slowly but surely.
Yeah, that's great.
Yeah.
That's great.
And then average age of survival after diagnosis, 4 to 8 years. We say in our clinic, we see our patients from diagnosis until death. That could be anywhere from 8, 10, 12, maybe a few more years after diagnosis for people who are otherwise really healthy. And that's a long time. That's a long time for the patient to be going through the disease process. It's a long time for the caregiver.
Yeah, that's tough.
Yeah. I'm going to do my best to describe the etiology of Alzheimer's disease, so how it makes its way through the brain. I'm not a physician. My knowledge of biology is based off what I know from my providers. I'm a social worker. But, I find this picture of the brain one of my most favorite to use, right? When Alzheimer's disease starts, it starts here. The temporal lobe, the hippocampus. This is where we see the center for memory, processing, and emotion, which is why it's no surprise that short-term memory, the newest information that we get in, is the first information that we don't remember with Alzheimer's disease, right? As the disease continues, it moves forward, up, and back. That's the movement of the disease process through the brain. We see it start to affect in those moderate stages, decision-making, planning, ability to pay attention to things, right? As we progress through the moderate stage, difficulties with movement and speech, right? We see a lot of our Alzheimer's and dementia patients, especially as they progress in wheelchairs. Why is that? Because the brain isn't making the connections to be able to walk, right? We see it affect all the way back down. And as we progress to that severe stage, eventually it affects the brainstem, and the brainstem controls those things that we don't think about: heart rate, breathing, those biological processes that we don't have to higher level consciously think about, but that the brain still controls. And that's why this disease is deadly, right? That's why this disease is progressive and doesn't get better.
But that natural progression you talked about, how it goes forward, up, and back, that's why people live so long with it before it actually affects those things.
It take a long time for it to get to those things.
I think you did a great job describing the etiology, by the way.
Oh, thanks. So as the neurons in the brain start to die off, so as that process, that forward, up, and back, right, the neurons in those spaces start to die off. And as the neurons die off, they form plaques and tangles, right, of proteins. And the plaques and tangles are clumps of proteins called beta amyloid. There's some other proteins in there, and they build up in the brain, and they contribute to the development of Alzheimer's disease. Neurologists know several biological markers that indicate Alzheimer's disease. They can't quite figure out which one is the primary cause of Alzheimer's disease. So we're hearing a lot about beta amyloid right now, because this is the one that neurologists and researchers have really been able to focus in on, right? I love showing an MRI. If I could show MRIs to everyone, I would, because it makes so much sense when you see it broken down on a screen for you, right? This is a brain of someone who doesn't have any cognitive changes, but is in older age, right? There's not a lot of space here, not a lot of space in the third ventricle. There's not a whole lot of atrophy, right? But as we move over to mild cognitive impairment, which is the stage in between normal cognition and Alzheimer's disease, we see a little bit of atrophy here. These are the temporal lobes, right here. This is the back near the hippocampus. Right? This is the third ventricle, and we see all that extra space, right? And then we look at the patient who has diagnosed Alzheimer's disease, and there's more space, there's more atrophy around the brain.
I mean, it's so obviously clear when you look at these three pictures next to each other. It's completely impressive.
Yeah.
You don't really need any training to see, holy cow, what a difference.
Yeah. And again, I say this to family members exactly this way. I had to say it to my grandfather when my grandmother was diagnosed. It's not the nicest way to say it. It's not the prettiest way to say it, but the brain is dying off. Quite literally, the brain is shrinking, right? And the centers that used to control those things don't exist anymore. And it's so plain when you see, like the first time I saw an MRI, it like blew my mind. So that's why I love showing this picture.
Yeah, impressive.
This is another one that I enjoy showing. It could make people a little queasy, sorry. A brain that has not atrophied versus a brain with Alzheimer's disease that has. The brain shrunk, significantly smaller.
Mm-hmm.
So when we go through the stages of Alzheimer's disease, I like to go through Alzheimer's disease and describe it kind of like a cliff, right? And we use the three-stage model. There are other stages, but I like the three-stage model easier. It's just easier to remember. I like it best. That three-stage model is kind of like a cliff. Like those 10 warning signs, that early stage, you don't really notice it until you start to notice something's wrong. Mm-hmm. You don't notice it until it looks like my grandma Honey, who went to the fridge for something and presumably needed her glasses to see something, and then took her glasses off, got the thing she wanted out of the refrigerator, and moved on with her day. And 10 minutes later, Stewie, have you seen my glasses? Now, this is not uncommon for my grandmother. Losing her glasses is not uncommon. It's not uncommon for my pop-up Stewie to have to go find them. But when he asked her, well, where did you last have them? She couldn't tell him, and she couldn't retrace her steps. And eventually they found the glasses in the refrigerator. She must have put them down and closed the door, right? But she couldn't retrace her steps to get there. That's early stage. Early stage is sitting down with my grandma Honey, who says, have I ever told you about my friend Doris? I say no. She tells me the story. I walk away. I come back 10 minutes later. Have I ever told you about my friend Doris? Right? Yeah. Or it looks like my grandmother, who got in the car with me. I'd gotten my first big girl job, and she wanted to drive me to the Boca Mall. I was visiting her. She wanted to drive me to the Boca Mall to get me some professional clothing. And on the way to the mall, she calls my pop-pop Stewie and says, Stewie, how do I get to the Boca Mall? I'm on Jog Road, but I can't figure out if I go here or there, right? She'd driven to the Boca Mall several years. I mean, they've been down there for 20 years at that point. She'd driven there many, many, many times over, right? But finding your way, driving a familiar route is hard all of a sudden, right? And those are the three primary ways that they show up, right? Early Alzheimer's disease typically shows up either visual spatial difficulties, getting lost, driving a familiar route, repetition, over and over and over and over and over again, right? Or word finding difficulty. You know, I just, you know, that tip of the tongue phenomenon where there's a word you're thinking of and it's not quite coming out, but it's almost there, right? That it's called aphasia, right? And those are the three ways that it typically shows up most often, right? As we progress from the early stage to the moderate stage, we're going to see a real decline in the person's ability to do a whole lot for themselves, right? This is the stage that most people think about when they think about Alzheimer's disease. This is where we see repetitive behavior, more agitation, more anxiety, more restlessness, right? We see a change in mood and behavior and personality because they used to be able to, and they're so frustrated and they don't know why it's not working anymore. Why can't they remember, right? But remember that those centers of the brain are atrophying, so they're not going to, right? And we're also going to see more incontinence, bladder and bowel. We're going to see difficulty reading and writing. We're going to see changes in sleep. They're either going to sleep more or sleep less, or they're going to sleep at weird times of the day and they'll be up all night, right? Or they'll lose track and time of their surroundings. My grandma Honey used to get ready for an 11 o'clock doctor's appointment and be at the front door waiting for my Pop-Pop Stewie by 8 a.m. I'm ready to go, right? Honey, your appointment's at 11. We live 10 minutes away.
Right.
But that didn't compute, right? She didn't understand time.
Right.
8 a.m. looks like 8 p.m.
Mm-hmm.
You sleep for 2 hours, you wake up, it must be morning. You slept, right? That's your moderate stage. And that's going to get worse over time. And as it does, as we've gone off that cliff and as we get worse over time, we're going to see patients that need more and more hands-on care. These are going to be our severe stage patients. These are going to be our patients that come in inpatient for an acute issue, but chronically, they don't speak to you. They can't convey anything besides maybe yelling a little bit or their eyes open or closed, right? They need to be turned in position. They need to be fed. They need to be cleaned. They need to be probably a bed bath of some sort because getting them up and in a chair is really difficult. They're more brittle, right? These are our severe stage patients that are close to the end of that disease process. And it's heartbreaking, those patients. That's the stage that a lot of people have to think about nursing homes and think, God, I could never work with that population, right? Why is it important to get an early and accurate diagnosis? It's important for the patient because in those early stages, we want them to make as many decisions for themselves as possible. They need to understand what's going on with themselves. And they need to be able to understand why, at least in the early stages, and as we move to the moderate, why their loved ones are going to start making decisions for them. That's going to be really hard for them to swallow. That's a hard pill to swallow. Right? For families, they need to start facing the process, what they're going to need to expect, how they start making informed decisions, how they make future plans with their loved one, how they access any support services that they need now or that they're going to need later on in the process. That's why we do what we do. That's why the CIAs exist.
Right.
Right. So what does it mean to see a neurologist, to see a specialist who works in Alzheimer's and dementia care? We tell family members, if you notice any of the 10 warning signs, make an appointment with your primary care provider first. They're your first point of contact because they likely know the patient better than anyone, besides their loved one, that is, right? So you need to talk to your primary care provider. From there, primary care provider will make a referral to a neurologist. Hopefully it would be us because my doctors are experts in this, but if it's not, a neurologist should be able to diagnose dementia, right? From there, you got in to see the neurologist. What happens at the neurologist's office? What are they going to tell you? How do they diagnose it? So what we do in our office for a new patient visit is that a nurse and a social worker will take the patient and a caregiver, an informant we call them, back
Mhm.
into an exam room. We always want an informant with the patient. Because when we're talking about memory loss, we're talking about varying degrees of insight, right? The patient may see certain changes and may not want to tell us, right? They may be terrified of losing their independence. They don't want to tell us, right? Or maybe they're ashamed of it or embarrassed, or maybe they're simply not remembering the changes that the families and caregivers are noticing. Family dynamics can get complicated, might not always be a spouse or an adult child. Maybe it's
That never happens, does it?
what?
Do you have complex families?
Never.
Never.
Never. None of us have complex families.
No.
It's yeah. So sometimes we see a church member who knows them really well, or a neighbor who's doing a really good thing for someone if they don't have other family around, right? But we need someone at this appointment, right? So we take the two people back into an exam room and we'll ask 10 to 20 minutes worth of assessment questions. It's a long time to spend with a patient. We want to know, what memory changes have you been noticing? Is it getting worse? When did it start? Can you give me examples? Is the patient still driving? And if they are they getting lost driving familiar routes? How's the house look? Is it cooking? Are they cooking and cleaning for themselves? If they're not, how are they getting food? How are they eating? Are they managing their own medications? Any mistakes? Have you noticed them not taking anything? How are they managing finances? Fallen for any financial schemes legally? If not, has any money gone missing? Are they not paying their bills? Do they not notice the mail coming in, right? We want to know any personality or mood changes that family or friends have noticed, right? Because we know that happens in moderate stage.
Mhm.
We want to know, have you had any sleep disturbances, any falls and hit your head? Is there any family history of dementias? We want to know as big and comprehensive a picture of the person as we can, right? And then we do a cognitive assessment. Assessing for Alzheimer's disease and other dementias, we use 2 paper and pencil cognitive assessments. We use either the mini mental state or the MoCA, right? The Montreal Cognitive Assessment. The MoCA is our more sensitive assessment. This is the one we do on people whose family are noticing slight changes, but they're really not sure, right? And this measures all of the primary ways we see it show up, right? These are visual spatial questions. The clock is certainly visual spatial. Can you put numbers in a clock and give me the hands at the correct time that I tell you I want drawn in? Can you name the animals? Can you remember words that I give you at the end of the test? Can you sequence things and pay attention to instructions, right? All of this measures Alzheimer's and dementia. And the score is out of 30, right? Anything in that 26 range, you're probably fine. Anything below 26, anything 26 to like 18, we're thinking mild stage, right? Maybe mild cognitive impairment or mild stage Alzheimer's disease or dementia, right? As we get a little bit further down the mark, as we get towards 15, 12, 10, then we'll switch and we'll do a mini. The mini mental state exam is less sensitive, right? The questions, they're a little small. I didn't make it any bigger, I'm sorry. But the mini mental state is less sensitive, less specific. But again, same questions, orientation. Can you tell me where you are? Can you give me today's date? Can you give me the season we're in, right? Can you do math? It's the same question here. If I start at the number 100 and subtract 7, can you keep subtracting until I tell you to stop? And this is all verbal. They don't get to look at these, save for the visual spatial questions. This is a verbal test. They have to give me the answer verbally. So can they pay attention and give me those answers? Are they able to do this test? I show them a pen. Can you name this? Can you name a watch, right? These are word finding things, right? Can you copy the shape? Can you write me a full sentence? And again, anything 26, we're probably okay. Anything around 21, we're mild stage. Anything 10 to 20, we're definitely moderate stage. Anything below a 9, we don't really test them anymore because we know that they're headed towards severe stage. As we're doing all of that with the patient, my providers will be looking at MRIs, CT scans, any doctor's notes, anything to get a better understanding of who this patient is. We'll put all of this information together, including caregiver paperwork that the caregivers fill out about patients' ADLs, IADLs. Can they take care of themselves? And if they can't, how is that changed and when? Do they need more cueing, right? Are you noticing any depression, any anxiety, any other neuropsychiatric symptoms, hallucinations, delusions, anything like that? We want to hear from the caregiver too, so they get a set of paperwork too. All of that, my providers can typically make a diagnosis, typically. And that's complicated because most providers won't make a diagnosis that quickly. And sometimes we have to watch them for a while, right? We see our patients anywhere from 8, 10, 12 years. My patient's diagnosis could change if we see new symptoms happen. So we got a diagnosis. What do we do next, right? And again, we're outpatients, so this is not typically an inpatient process, but we're talking about community health. So we're talking outpatient, right? The goal is that they're going to go back out to a community and live at home, right? What the patient and the family decide to do next typically depends on the severity of the diagnosis and what stage the patient is in, right? We're in community health, so I'm not typically going to talk about moderate into severe stage. I'm probably going to stick mild to moderate stage because we're talking about people going out into the community. But recognize that as I'm giving you all of the community health information, as I'm talking about community resources, they can be manipulated to have a person home through the moderate to severe stage. It's just much, much harder, and also much harder on the caregiver.
It's got to be so tough for caregivers.
It's heartbreaking.
Yeah. Yep.
So first thing to remember when your patient and your loved one is getting set up back into the community is that there are lots of factors we need to consider, and that the family is likely going to be overwhelmed and confused and probably incredibly emotional about this diagnosis, whatever the diagnosis of dementia happens to be, right? We need to remember that what's right for one family might not be right for the next. So I'm going to give you all of these resources, but not every family is going to need them all, right? Family dynamics and family availability are going to play a huge role in what the family chooses to do. And we have to consider dynamics, finances, health insurance, long-term care insurance, where the person lives geographically, and then the person and family's family preferences. And what would the person want? What's safe for the person? There's so much to think about. And I always think about like a big, massive cloud. I don't know if anybody's seen the meme that goes around on social media of like a therapist sitting in a chair and a person talking, and it's like this big cloud of confusing stuff, and the therapist rolls it up in a neat little ball as they're talking. Right?
Yeah.
I love that meme, but this is what it feels like for our caregivers.
Yeah.
There is so much to consider. So I'm going to start here at geriatric care managers. These are people who can really become a primary point of contact for families and patients. Geriatric care managers, typically social workers or other professionals who know the services available in their practice area, pretty much inside and out. They will work with families and hold their hands and make any service connections that are needed. They can become the caregiver shoulder to cry on, an advice giver. I've just given you 3 that I know of in our area: Care Patrol, Choice Connections, and Care Manage for All. Care Manage for All is Tanya Zalman-Schwartz. Choice Connection is Renee Birnbaum and Melanie Pratt, and they're wonderful. And you know, some will provide their services to families for free. Some will do a sliding scale payment. Some have a payment system, and they may not take insurance. So it kind of just depends on what's right for the families. They want that. But a lot of families don't use geriatric care managers, from what I'm seeing.
They don't use them?
I've only seen them used when people need situational things. When
Gotcha.
people need placement help, they'll go to Choice. I'll send them to Choice Connections or something. But more often than not, I don't see it used as often as I wish people would use it.
Okay, good to know. Good to know. I love that some of these are available for free. We never hear that word.
Never. And
Never.
again, it depends on the personal situation. I know, like Choice Connections, I know Renee and Melanie care so deeply for their families that they will work with the family to make it work as the family needs.
That's fantastic.
So it's, again, place by place, person by person.
Yep.
I want to mention the New York State Office for the Aging, NYSOFA. It's a state office created by the Older Americans Act during its first reenactment several decades ago. There are state offices for aging in every state. The Older Americans Act is a national act, so there are state offices for the aging in every state. So NYSOFA provides New York State's older adults with information about programs and services that they can access to allow for aging in place rather than placement in a long-term care facility. I'd love to navigate the website, but I don't quite have the time. But this is a live link, so you could click on the link, or you could just type it in aging.newyork.gov and play around on the site. So these little rectangles here will lead you to lots of different links in the New York State website. And there's lots of programs and services.
Great, thank you so much.
Now, the state offices for aging are responsible, so this is Older Americans Act, state offices for aging are responsible for county offices for aging, right? So we've got kind of like this like inverted triangle thing happening, like a funnel, right?
Yeah.
So every county in New York State has a county office for the aging. I've just inserted pictures from Albany County because I live in Albany County. But the county OFAs will have the better information for caregivers and nurses if you want to investigate a little bit about which programs and services are open in your county. And remember, when you're at the local, you need to look at the local level for your families and caregivers, because that's who's going to be coming into the home. It's not going to be coming from the state. Albany, capital Albany can't do anything. Like local is probably your better bet to move down, right? But they'll know what exists in their counties. They'll be able to help connect you to those services. And they're going to know things like congregate meal programs out in the community. Work in conjunction with the local Meals on Wheels program, right? They're going to be able to tell you what agencies in the area actually have companion or personal aids to give you and how many hours they have to give you and what the payment's going to look like, right? And we'll go through what that looks like later. But often we direct our families to the county OFAs is another good place to start. Again, another live link for New York Connects. New York Connects is a database that was created and kept up by NYSOFA, the state office for the aging, right? You can navigate this website, do your own research about services and programs in the community. New York Connects works for all New York State counties, not just the capital region. But I would say, I think in my last 6 months here, and at least from the last time I've presented for this class, Anne, I think I've learned more about programs and services by going to the local OFAs, so your county OFAs, or word of mouth, honestly.
It's amazing how powerful word of mouth is for all pieces, isn't it?
It is.
It drives so much of what we do.
You know. I want to talk about the New York State Department of Health. They created that Alzheimer's disease program initiative, right? And there are 3 parts to this. Us, the CADS at Albany Med, the Alzheimer's Disease Community Assistance Program, which the Alzheimer's Association handles, and then the Caregiver Support Initiative, which more typically Eddie Alzheimer's Services and Catholic Charities typically do the bulk of that, right? But the Alzheimer's Association is involved in this too. So this is one of our brochures. You know a lot about who we are and what we do already, but I wanted to show you at least our brochure and what's out there, right?
It's fantastic to see.
And I have a ton of them. Don't pay attention to this because that's not an accurate space anymore in Clifton Park. But if you needed brochures, I could certainly get them to you.
Actually, you know what? Let's talk about that after. That would be fantastic.
Okay. Eddie Alzheimer's Services. They are one of the service organizations who initially received the grant funding for the Caregiver Support Initiative. It's again, that partnership between Eddie Alzheimer's Services, Catholic Charities, the Alzheimer's Association, and the goal of that grant is to provide free support and respite for caregivers who are dealing with or caring for their loved one with Alzheimer's and dementia. Being a caregiver is exhausting. It's hard work. It's long hours. You're not thanked. You're not forgiven for anything. It's seemingly never ending, right? Respite is quite literally a break. That's what the word respite means. It means break. And this grant, specifically through EAS, the Alzheimer's Association and Catholic Charities, literally has hours funded by the grant to give to caregivers who need a couple of hours break, right? They will partner with personal care aides and companion care aid organizations, and they will literally give the caregivers a few hours of respite a week, if they can. It depends on how many hours they have left in the grant to give, right? But you know, it's one of those services that allows our caregivers to shower and food pack, right? And run their errands, or even take an hour and just lay in bed and nap or cry or call a therapist, or literally anything that your caregiver needs to do. They're going to have trouble doing it when they're caring for a loved one with Alzheimer's and dementia. So respite is a huge relief, right?
It can absolutely help you survive this.
It's unbelievable what aides do, and they're not paid enough for it, by the way.
Okay.
If a patient's going to remain in their home, in the community, chances are they're going to need something like PT or OT or a visiting nurse at some point, right? Family's going to call us and say, well, they're not walking as well as they used to, and I don't have the house for a wheelchair, and I don't know what to do. PT, right? So there's an EDDI visiting nurses program here in Albany. They can provide PT, OT, nursing care, palliative care teams, social workers, home health aides. They cover several counties, actually. But here's the thing about getting visiting nurses in the home. A patient needs a referral and has to be considered eligible. And the patient has to have been seen by their doctor within 90 days of that referral going out to the Visiting Nurses Association, whether that's EDDI or Albany County, right? So we need to make sure that our patients are considered eligible. We need to talk to our providers. And these are the little details about getting care in the community that maybe places won't tell you until you've tried to send the paperwork to them and they won't accept them, right? These are the little things, the little details that could come back to bite you in the butt if you don't actually know them.
Gotcha.
Yeah. ISEP, it stands for Expanded In-Home Services for the Elderly program. It's in every county.
Every county has an ISEP? That's great.
Counties should have ISEP programs, yep. ISEP is provided by the state and local funding within the counties, but they provide non-medical care in the home for older adults. So this is not going to be your nurses, right? This is going to be your companion aides who can help bridge that gap. And that gap could be housekeeping, respite, case management, shopping, cooking. But these are our older adults in the community that aren't eligible for Medicaid, which means they're not eligible for Medicaid aides to come in and help.
Yeah.
These are the people who had enough money to stay home and have their loved ones help them out. So they're not eligible for Medicaid. They may have Medicare, but they're not eligible for Medicaid, and they need to kind of fill that gap because their loved ones are working. Right.
So basically our middle class people, right?
Pretty much. And our rapidly growing types of middle class.
Yep.
Right.
Yep.
So now older adults are utilizing ISEP and are expected to cost share and help with the cost of their services, but that's the sliding scale. It's kind of based on their income and the cost of the services that they're going to receive from the ISEP program.
Great.
Time check, 4:04. I've got till 4:30. Oh, I got to speed up. Okay. Medicaid facilitators. So our Medicaid facilitators are Healthy Capital District Initiative, Independent Living Center of the Hudson Valley, and Southern Adirondack Independent Living Center. They let us, a lot of us know that Medicaid is state assistance. It's an assistance program, right? And it's only intended to be a stopgap, right? To help out our more vulnerable populations, including our elderly. But that process of signing up for Medicaid, if you've ever had to do it, I did when my health insurance gapped, it's not intuitive. It's arduous. Mm-hmm. And it's a thorn in the side for many of our caregivers, really. So these are services that are going to help their families get Medicaid. Some of the service providers we send our family to are these ones, but these are the people that are really going to help the families through the process. Families can call them, hasn't gone through yet. It's been 2 weeks, why haven't you called me? Like this, these are the people that need to be called. What's an MLTC? So one of the biggest things we see for older adults who are on Medicaid and Medicare are the managed long-term care plans, MLTCs, right? MLTCs provide home and community-based services to individuals with long-lasting health problems or disability, but they have to have both Medicare and Medicaid to be eligible for an MLTC. And these are services that will pay for things like home health aides 24/7, adult day programs, home delivered meals, transportation to medical appointments if the person's homebound and can't drive, right? They'll typically cover task-based services, bathing, dressing, toileting, med management, meal prep. They don't typically cover companion care, right? But again, these are our patients who need more physical help to do the things we used to do. MLTCs, if you need 24/7 care in the home, you need an MLTC. Because I don't know very many private aid companies that will pay for that 24/7. And if you need to pay for that 24/7, you're going to be spending a lot of money. And at that point, you're putting in a lot of effort. God forbid someone doesn't show up to their shift, then you have to cover. And that means you're losing work, or you're losing your kid's soccer game, or you're losing your kid's dance recital, or, you know, it's things like that.
Yeah.
And that's typically when we get to the point where we either do 24/7 aids or we do long-term care.
Right.
I've talked about companion versus personal care aides. Your companion aides are the people that spend time with your loved one and give you a break and do things like, you know, do activities with them in the home, or maybe they take them food shopping if the person wants to go food shopping, right? Your personal care aides handle your ADLs. Companion aides are IADLs. Personal care aides are your ADLs, the dressing, the toileting, the physical help that you need to be certified to do. Things like Meals on Wheels and senior centers, right? There's lots of those, and they're not typically always funded by the state, but they might have local grants and stuff, right? Meals on Wheels is a program that delivers meals to seniors who are homebound. They don't leave their houses. It's a really good option for those seniors who want to stay home or in their communities, but they can't cook and they can't food shop anymore, and their loved ones might not be around, or might not be able to give them food, right? Cook for them and drive off. The other thing to note about living in the community is that senior community centers and senior service agencies provide a lot of these same services that we've already talked about. They all inevitably have someone like a social worker on staff. Inevitably, right? And these are places that could also provide, activities, community programming, a congregate meal site maybe once a month, right? And some of these providers on the slides, these are just a few of what exists in our capital region, right? JFS, if you've worked with the NORC, you know they have stuff like this. Meals on Wheels, Life Path, Catholic Charities, they all provide services to seniors in the regions that they serve. Tracking devices and wandering concerns. As we move into that moderate stage of dementia, patients don't know when and where they are. They really might not know. They've lost their orientation, and now they're wandering and they're walking out of the house. And now they're walking down the street. And then I get a call from a loved one. We got out last night. We had to call the police. The police dropped them off. It was scary. How did she know? How didn't she know to not go out the door? It seems almost like a too easy, almost like a scary, like, why would I put a tracking device on my loved one, right? There's something called Project Lifesaver, right? All the police offices, all the county police offices in the area should have a Project Lifesaver program, right? And it's just a GPS device, a tracking device in a bracelet looking thing that will transmit a GPS location to that police station, right? The transmitter submits a signal to a specific FM radio frequency. That frequency gets tracked, right? The other thing I've told families is utilize these little things right here. They're not GPS, but they can go on the side of a door in your home. They can just be purchased, could be battery operated, and you put them on the side of the door. And when it's locked, if the door opens, the alarm will go off and it alerts somebody in the house that the door has been opened.
Oh, nice. That makes sense.
Yeah. Or you can utilize a camera, right? You can have a camera system and an alert go off on your phone that says somebody's walking out the front door, or there was movement by the garage door, right? And that'll alert somebody, a loved one, even if they're not in the building, even if they're outdoors doing some gardening, but their loved one has walked out the door, you know.
Nice.
Advanced care directives. These are your considerations, like your healthcare proxy, your MOLST, your medical orders for life-sustaining treatment that talks about, do you want to be intubated? Do you want to be resuscitated? Do you want to be hospitalized? Do you want antibiotics if you get an infection? A lot of these things we implore families to have done in that moderate stage, or in that mild stage before the patient moves to moderate, because this requires signatures from a healthcare proxy or the patient. But we want to know what the patient wants done. And when you think about moderate stage to severe stage, I mean, these are chronic condition dementias. They're not going to get better. They're only going to get worse. And that person's going to get sicker when they have acute care issues. If they have an acute care issue, if they stop breathing, if they code, as an example, when they're in the hospital for a bout of pneumonia and they code and they're in that moderate to severe stage, do you want somebody to crack their chest to resuscitate them? If you don't, you need to make that choice. Now, advanced care directives are really, really important. And I would even argue, I'm 26, I'm about to be 27. We should all have these done now ahead of time. You can change them as many times as you need to. You should have these in place. God forbid something happens to you, who's going to be the person to be your healthcare proxy and make decisions for you? And your doctor will do it only if no one else will. And they're going to make the choice to keep you alive because that's the oath they took, right? So think about that. If that's not something you want in an end-stage dementia patient, what do you want done? Legal and financial. I'm sorry?
So important. I wish it was done along with our licenses. Like, to me, you make that decision about organ donation. Why don't we have the same thing about pointing a proxy and figuring these things out? But
Legal and financial help is another big one we see come up often in this moderate stage of dementia. Who's power of attorney? Who's taking control of selling the house if we need to have our loved one move in with us? Who's taking care of the living will? Who's going to take care of the person's assets? Their social security check when it comes in? Who's going to be controlling that, right? And then we have to think about these older adults with no insight, who never moved in with their loved ones, who are now being taken advantage of by a girlfriend or a boyfriend or someone who's staying with them and living with them. And they trust them, but they may not have insight. And now the daughter or the son says to me, but there's nothing I can do. I can't tell her she has to sell the house. I can't kick them out. No, not unless you're power of attorney. Appoint someone to take care of your legal and financial matters if you can't. And in those moderate stages, my patients can't. They can't make decisions for their health care or their money. Their brain is literally shrinking, right? The centers of their brain that control their ability to make judgment calls has shrunk and died off. They can't, it's a medical diagnosis. They can't do this. We're not calling them crazy. It's a medical diagnosis. Appoint someone to do it early, please. God, please.
Yeah.
Still driving? Let's talk about it, right? Is your patient still driving? Do you think that they shouldn't be? Are there little scrapes on the sides of the cars, or like a light on one of the sides has gone out? The centers of the brain that control communication to the eyes and seeing in front of you in the windshield dies off, right? Our eyes can't see peripherally anymore. That it's just not possible, right? There are driver rehabilitation programs. There are driving evaluations. The one I'm showing you here is Sunnyview, part of the St. Peter's network. We prefer Sunnyview because it's an actual on-road test. There is a physical paper test component, but then an OT, a trained OT, will get into a specialized car with the patient behind the wheel and let them drive, and we'll make note of judgment calls and peripheral things and speed and literally everything you need to think about when you're controlling a vehicle on the road. they will make a recommendation to the patient, whether that's only drive during the day, only drive familiar routes, only within a certain mile radius, or we recommend you not drive. We get all types of recommendations from them, and my providers will write a letter to agree with them, sign off on the OT's recommendation, and we will have to pull a license if a person doesn't listen to that. We will have to contact the DMV and have the patient's license be taken away if they don't listen to those recommendations. It's
Is that something your provider does, or is that something the driving school does?
something my provider does. So driving school,
Provider does.
evaluation, you need a referral to do it. And there's a significant cost. I mean, this Sunnyview program is a couple $100s to do. I know the DMV does a driver exam, an evaluation exam. The DMV will do it. I don't know if it's free or what, but it's probably not going to be as good as this one, honestly. But my patients hate this because this is the loss of their independence right here. This right here is them being told that they're no longer allowed to be independent, to get in the car, get behind the wheel, and go where they want to. And they can't because it's not safe. It's not safe for other people or for themselves. Caregiver considerations. We've talked about respite quite a bit, but here we have to talk about self-care. So what is your type of self-care, and recognize that when you're a caregiver for a loved one with dementia or Alzheimer's, you might not be able to do it, right? My self-care is going to the gym, but if I'm a caregiver full-time with my loved one with moderate stage dementia at home with AIDS after work, I don't get to go to the gym. I have to go home and take care of my loved one, right? So we need to think about how our loved ones and our caregivers get respite to self-care. And maybe that self-care is 10 minutes. They walk away from their loved one for 10 minutes with the TV on in front of their loved one, right? But maybe that self-care is going to your employer and asking for FMLA and making sure that you have the time to take care of them during the day, right? At the end of life, we have to consider the important questions about when do we stop treating for acute care issues? When do we move to comfort care? When is it time for hospice? Now, hospice was originally designed with cancer in mind. It was not designed for Alzheimer's disease in mind. This is like a 6 months to live situation. And unfortunately, we don't know how long our Alzheimer's and dementia patients are going to live until they do. A lot of my severe stage Alzheimer's disease patients that'll last like 2 years in that stage, maybe even longer, will be comfort care only. A lot of these patients will stop getting, their families, their healthcare proxies will stop giving them their heart medication, will stop giving them X, Y, and Z, because what's the point? It's a progressive disease. Put them on comfort care. And if you're interested in looking at the difference between palliative care and hospice care, I sincerely implore you to check out the palliative care program at Ellis. It is going to become St. Peter's. I think a lot of us know that at this point. But look at it because Ellis has a palliative care program.
Nice.
I think the Eddie does too. I think St. Peter's does too. A note or a moment. I can't put those words together, Rachel. A note on APS. A lot of people see APS and they think CPS. You're going to take my loved one away the same way you'll take my child away, right? It's not the case. APS is so very different. APS is helpful when you, a family member, a caregiver, really anyone suspects adult abuse, older adult abuse, with Alzheimer's or dementia, or when there's no one around to help care for that patient, right? Like I had a patient come in who had no family, had alienated his brother and sister, never married, lived alone in a very rural county with a dog and a cat. And he came in with his neighbor who looked at me and she said, I can't do this anymore. Someone else needs to come in. I can't, I'm doing a nice thing, but I can't. I have my own job. I have 2 kids. I can't help him anymore.
Right.
But then I think to myself, if I were in his position, I would want him to do this for me, but I'm floundering. Every day he calls me over multiple times a day. And I knew talking to this patient that he was not well, right? The word finding difficulty, could not put sentences together. The words he did string together didn't actually form a thought. He was very angry and agitated, very paranoid about the people around him. She was bringing food over every day. The house was a mess. The cat and dog had not been cared for in years, right? These are the situations where there's absolutely no one. Then we call APS and they open a case, and that person becomes a ward of the state. I've had family members call and say, in difficult spots, say, my loved one won't let me help them, but I don't have power of attorney and I don't have healthcare proxy and I don't know what to do and she hates me so much. And what are my options? Your options are to either keep helping her as best you can or call APS. And if you call APS, you can't be involved at all, period, end of story. If there is a family member involved, APS is of no help to you. It's hard. It's like a hard line in the sand. And the reason it's a hard line in the sand is because APS deals with adults. When you're dealing with children, children need someone to look after them. But adults who don't have a diagnosis or who are in mild stage, they have the self-determination factor that comes into play. Adults get to make their own decision unless and until a doctor says they're not able to, they don't have capacity to make their own decision. At that point, APS gets involved. Right? There's hard lines in the sand. APS doesn't just serve my Alzheimer's and dementia patients, they do serve 18 plus with physical or mental impairments, unable to protect themselves for abuse, or who have no one available and willing to be able to assist them responsibly. These are a list of services that they will do. And this long-term involuntary intervention, that guardianship, is when somebody becomes a ward of the state and gets placed in long-term care, and the state is in charge of their well-being. There is an APS in every county. Whether they have enough workers to manage the county, that's county by county. Basic tenets of APS, so you understand why: self-determination, least intrusive interventions, least restrictive interventions. They don't want to walk into somebody's life and put interventions in place. And avoidance of blame or judgment. We're not saying to the older adult with dementia, it's your fault, you can't take care of yourself. We're not saying that. What APS is saying is that this is the situation we're in, and unfortunately, it's not safe for you to live here anymore by yourself. These are eligibility requirements. Again, no one to help, no responsible party, a decrease in capacity. This word capacity is big for little stuff like this. Do you have the capacity to make your own decision? Any questions? Wow, I got through it with 5 minutes to spare this time, Anne.
That's pretty amazing. Great job, Rachel.
Thank you.
I learned so much from you every time you talk to us. It's just really phenomenal. It's amazing all the different possibilities that are out there for people. And it's so much related to just having the knowledge. I think that's a huge part of it for people, is knowing where to turn and how to get there. So
absolutely.
It's absolutely fantastic. Thank you so much for taking your time with us today.
Yeah, that's what I do. That's what I'm here for.
Awesome. I'm just going to stop our recording for us. So students, if you have any questions, just reach out to me. I'm happy to help pass questions along if we need to. But I think you'll really enjoy this. Hopefully everybody enjoyed listening to this, and it's great information. All right.